There are a lot of disclaimer for this talk. As being a IDF Southeast Asia chair, I'm not the expert in the field of diabetes and pregnancy. Rutul had asked me to talk on a global perspective. And the experts in field of diabetes sitting right here next to me, Dr. Rajiv Chawla, Dr. A.K. Das, Sunil Gupta, Rutul himself, and many more. I congratulate Rutul for this wonderful meeting. Congratulations to Piyush for organizing this meeting. What I am going to talk in next 20-25 minutes, the global perspective without any financial disclosure. My major interest is always type 1 diabetes, and I am involved with many type 1 diabetes activity. But I always say, my colleagues, physicians who are practicing diabetes, if you are not knowing type 1 or you are not practicing type 1, if you are not expert in field of diabetes and pregnancy, because that is something for which you are referred, and diabetic foot, that completes you a diabetologist. And I learned all this from Dr. A.K. Das. He's the guy who had trained us in a foot by, it was an international program on diabetic foot. He's having a lot of interest in diabetes and pregnancy, and simultaneously he was also chairing our CDIC National as a chair. Thank you, sir. And I'm thanking him again for giving me an opportunity before him, because I told him two things, sir, I will not able to speak after you. And the second is, I have one meeting at Sri Lanka and Southeast Asia, it's online meeting. Thank you, David, for coming India, and before a few weeks also we met just for the a very new continuous glucose monitoring which we were waiting since years in India, which will come maybe in another 3 or 4 months. Historical aspect of hyperglycemia in pregnancy. By 1950, the gestational diabetes was thought to be a very transient condition which adversely affecting fetal condition. The term gestational diabetes was introduced by O'Sullivan in 1961. The hypothesis of fetal origin of adult disease proposes the gestational programming is influenced by adult health and disease. But in India, the pioneering work which is done by Dr. Sashaya and his group and all his students and his daughter, where she is, the national daughter, she should be given, they all have done and the very interesting DIPSI program, which was the diagnostic standard for GDM. And maybe in this list, in historical aspect of HIP, maybe after 20 years or 10 years, Rutul name will be there for pregnancy study group also. The global prevalence, the evidence suggests that diabetes in all forms are on the rise, especially gestational diabetes. However, geographical prevalence and distribution is very uneven. The results indicate the global burden of GDM is high, and particularly in Southeast Asia. Combining all the studies have a global estimated prevalence of GDM 10.13%, median of 38.2 reported from Kuala Lumpur, and Ireland has a lowest prevalence of 2.075. Middle East and Asia, probably we have more in compared to European condition, estimated 60 million pregnancy. But whatever the data which has been published, 221 data sources, 131 countries who were selected for International Diabetic Federation in a diabetes atlas study, that is what from where I have taken. Only 37 countries were reported to have data sources. So that's very important. Even this is a data which has been given by International Diabetic Federation from 221 data source from 131 countries, but the data were only from 37 countries. And only 3 were from Africa. So even whatever the estimate we might do for one particular region, one particular country, maybe underestimate, we never know about it. Highest prevalence as far as India is concerned, it was seen in Punjab, but that does not mean, again, as I told you, because maybe less studies in other parts of the country or may be not done it also. IDF Atlas says very clearly that it requires more attention and more intervention too. 14% affected by GDM globally, and several risk factors are there. It is increasing BMI is very important, and more important that increasing age of a female of getting pregnancy. These are very two important reasons for them to have more risk of developing GDM or hyperglycemia in pregnancy. In Indian subcontinent, we have higher in compared to European population, but considerable variation was found in prevalence, and maybe because of socio-economic status and demographic factor. And there are many factors which are confounding sometimes, because in a study, whether you have taken between 18 to 30, 25 to 35, what age group also. So South Asian countries, very high. We also have the prevalence of adverse pregnancy outcome, which is preeclampsia, cesarean section, delivery, macrosomia, low birth weight, stillbirth weight, IUGR is high in South Asian countries. And that's again the reason, whatever the study and prevalence which is shown may not be perfect because of a lot of confounding factor. This we all know from HAPO study that hypoglycemia during pregnancy have adverse pregnancy outcome, and that's the reason we all need to treat a person with hyperglycemia in pregnancy. Different diagnostic criteria. When we were studying, there were multiple criteria were there, and then during our, in practice also. But what we should use, IAD, PSG consistently produce higher prevalence rate of GDM. Then other criteria, one was that reason was the fasting value was 5.1 millimole in compared to other. Although IAD PSG criteria has demonstrated higher sensitivity for GDM detection associated with fewer adverse outcome for both mother and child. And it is thought that overdiagnosis of GDM could predispose women to psychological stress, unnecessary treatment, and impaired quality of life. And this is what I have taken from a reference which has been just recently published. The diagnostic criteria are different, and we from India feel always proud to have our own criteria. That's a DIPSI criteria, which had become very easy for us to have. Yes, there can be a lot of debates, and I'm sure in last 1.5 days we will have another, in any meeting there will be a lot of debates against multiple criteria which are there. This is the DIPSI criteria. My very close friend Sunil Gupta, Professor A.K. Das, Shashank, Balaji, Shashaya, they have come. And they have involved people from all across the country. Dr. Rakesh is here, Dr. Mayur Patel from Ahmedabad is there, Dr. Rajiv Chawla, and many experts in field of diabetes and pregnancy who have written this DIPSI guideline. And that made our life much easier, because of instead of using 2 steps, we had gone for a 1 step. That was using a DIPSI criteria. The 1 step, which is of WHO approach and IAD PSG, was direct 75 gram OGTT at 24 to 28 weeks, while our 1 step is again different of DIPSI, that is non-fasting, giving once only and checking it after 2 hours. The 2 step was first you try to screen them and then you again do it. Timing was universally recommended. 58.5% healthcare professional in Asia and Africa and even Middle East, they still use 2-step process. So I mean, I'm here not talking of 2-step of taking 2 times sugar. I'm talking of 50 gram giving them a glucose tolerance test and then followed by again confirmatory test of giving them 75 gram glucose tolerance test. 1 step is identified more cost effective per evidence, but still this is what the data is showing, and no universal global consensus remain even. So I will be talking, and the WHO has released on 14th of November, World Diabetes Day, the data that what they should do, what is the global consensus, and healthcare infrastructure often determines approach which they use. This is what the WHO recommendation. It was on 14th of this month, on 14th November, on World Diabetes Day, they have come out. And why I have shown some interest in it, we all know about the 1 in 6 live births having a hyperglycemia in pregnancy. In review of pregnancy specific guideline, they've used 25 guidelines relating to diabetes in pregnancy were found. 25 were addressed on GDM and 4 were addressed on type 1 and type 2. Of which 18 were from upper, middle and high income countries. So this is very important. Even WHO had compiled the data, but they were having 18 guidelines which they have taken from upper and middle income countries. It was not only 7 were there, 5 were from international society. And given the disease burden of diabetes, the burden is a global, the most cases in low and middle income countries, guideline applicable to these environments are needed. So we don't have the data, whichever they had used in this WHO document, they don't have from the low middle income countries. The recommendation have 27 recommendation, 4 on core practice for caring the woman with diabetes during pregnancy, 6 on glucose monitoring, My interest is there for glucose monitoring. 2 on pharmacological treatment for pregnant women on type 1 diabetes, 4 on pharmacological treatment for type 2 diabetes, 2 on pharmacological women with GDM, and 9 on additional monitoring and assessment. So these are the recommendations which they had put 27 recommendations. And the recommendations are intended for use in addition to routine antenatal care. The glucose monitoring, that was my interest, and that's the reason I have taken from this. The modes of glucose monitoring. For pregnant women with type 1 diabetes, recommend the use of continuous glucose monitoring wherever feasible. I was part of 2017 International Consensus of Continuous Glucose Monitoring. And we put that all those who are on insulin all over the world, all those who are on insulin deficiency, using different type of drugs for that can lead to hypoglycemia should be on continuous glucose monitoring in 2017. This is what they are saying in type 1 diabetes. If they become pregnant, use CGM. For pregnant women with type 2 or GDM, do not routinely recommend use of CGM. And that was something which I felt that why it is they are writing. They are writing specifically in WHO in 2025. Do not routinely recommend use of continuous glucose monitor. For pregnant women with type 1, type 2, measure HbA1c in first trimester. That is what we do, just to know about the pre-gestational diabetes. Those who are clear-cut GDM or first-time detected hyperglycemia, I mean, not for the targets, you don't measure the HbA1c. Then you need, so one side you are writing that continuous glucose monitoring is not to be recommended, while the other side you are saying that for monitoring, you should now don't measure the HbA1c, it is definitely the self-monitoring of blood glucose, and then that should be the target. For pregnant women with type 1, type 2 and HIP, individualized glycemic target to optimize glycemic control, improve maternal and neonatal outcome. Just I will take another 30 seconds here. The case which I had shown. This female had come to me. It was in her 20th week. Her sugar, random sugar was one day before it was high. It was checked up by a gynecologist or her routine antenatal care obstetrician, and they referred to me. We had checked the sugar. It was actually, she had told that her sugar had coming high, and we got all the investigation, but HbA1c was absolutely normal. It was less than 5.9. So we asked her that let us put you on continuous glucose monitoring. And I believe that CGM in this particular person helped her a lot. Her diet completely changed. You can see only the first day. I'm not showing you the 14 days graph, but on first day only in light blue, you can see the sugar are high. While then second day, third day onward, when she was seeing her continuous glucose monitoring, all her simple carbs, which we explained her that what she should take in diet, you can see her sugar as absolutely normal. The most of the time fasting sugar was below 80. And the post-breakfast, post-lunch and post-dinner sugar was never more than 130. So this was the situation in a person. So how continuous glucose monitoring can motivate, educate, and a nutrition counseling can be done, even a person to whom otherwise we would have diagnosed her a patient of early GDM. The pharmacological management, the second interest was, for me, was in this WHO guideline was metformin. There was a debate was going on, but I am strongly using it in proponent for metformin, and it is increasing acceptance globally. It lowers insulin demand. FIGO and ADA increasingly support metformin as a first-line option. Reduce maternal weight gain and insulin requirement. PCOS-related GDM particularly benefit from metformin. Cost advantage in resource-limited healthcare system. That's again very, very important from India perspective. But then my good friend Rakesh will come out with some data to show IUGR, which I will also show, and I have taken some slides from him. Choice depends on local guidelines, availability and individual factor, and WHO guidelines recommend it to use it. What is early GDM? This is something very interesting. Just before some time, Rajiv Chawla was showing me the data not before 20 weeks, not before 12 weeks, even as early as 8 weeks of pregnancy also. Conventionally, screening of GDM is recommended between 24 to 28. We were knowing that GDM, if someone is diagnosed with sugar before that or early, we used to call, when we were doing our MD medicine, we used to call it maybe pre-gestational diabetes. And then later on, we understood even their HbA1c is normal. Should we call them pre-gestational or not? Should we call them early GDM? But DIPSI, and I remember Dr. B. Shashaya in his talk, as early as the first antenatal visit, please check the sugar. Now, the new term had come, early GDM, but I think he was saying this since last 15 years. And that is what, even at the time of first antenatal visit to the obstetrician, please check the sugar also. So type of gestational diabetes we can divide into early and late gestational diabetes. Early mean before 20, gestational diabetes late mean between 20 to 28. And now I could understand from Dr. Rajiv Chawla, we can call it early, before 12 or before even 8 weeks also. The diagnosis is based still on 2010 HAPO study, IADP, SG proposed a diagnostic criteria. So for early GDM, the diagnostic criteria is not different. The same criteria they had used. And women are tested in the first trimester of pregnancy, fasting plasma glucose more than 92 and less than 126. That's very important. And this has been published in 2010 also. This slide, Dr. Rakesh had given me, that this is what you call in 24 to 40 weeks, typically gestational diabetes. This is what, when we were studying, if sugar is more than 125 or more than 200, you will call it pre-gestational if it is before 24 weeks. And this is what, if someone is detected during that time, it is early gestational diabetes. So this is what early gestational. Is treatment of EGDM is effective and safe? And we all heard from Tobogium, the main person who was here, and we all know that it is effective, it is safe, and his recommendation, we take it. This is his paper in New England Journal of Medicine, and his main finding was it provides proof of benefits treating early GDM. Beneficial effect of treatment of early GDM demonstrated in a randomized control trial for the first time. Its results were more significant in those with higher glycemic band and those screened before 14 weeks of pregnancy. He had shown also the cost effectiveness. That is what very important. Should we do early GDM detection and treatment? And he had shown, and this paper is published for that cost effectiveness of diagnosis and treatment of early gestational. This is paper with Mohan and a group, and internationally many more people. He talked about the global burden of early pregnancy gestational diabetes, a systemic review. This is a review article which has been again given a slide from my close friend Dr. Rakesh, and there is a debate whether we should treat the early. This is the screening and treatment of early onset diabetes, a very systemic review and a meta-analysis, which he has given this slide with a 13 cohort study, where you can see the neonatal hypoglycemia is increased by using them, by treating them. So it's not that if only a nutritional supplement, a therapy which you are doing or nutritional recommendation which you are doing, or by putting them on continuous glucose monitoring, probably will not have defect. But this is published in 2017. But I have shown you before that the data of the treatment benefit also. But this is one also a paper which was talking of a systemic review and meta-analysis with 13 cohort study. Does treating hyperglycemia improve outcome? And this paper is showing that early GDM women and their offspring are at greater risk of an adverse pregnancy outcome compared with those who are diagnosed at 24 to 28 weeks. In view of the abnormal post-midnatal glucose finding, early GDM may reflect more advanced stage in diabetes pathogenesis. This is what a strategy for diagnosing GDM by IID PSG threshold in early pregnancy and providing treatment in all patients with early pregnancy did not improve the pregnancy outcome, but rather there is an increased risk of small gestational age also. So there is a debate whether to intensively treat this person with early gestational diabetes too. A very delicate balance, particularly from Indian condition, as we have a lot of malnutrition too. So both adequate nutrition and metabolic control are very important. Plasma glucose values in pregnancy hang on this delicate balance. If the mean plasma glucose is less than 87, there is a possibility of IUGR of fetus, and more than 104, it may be large gestational baby also of fetus. This is a 2024 Flemish consensus on screening of gestational diabetes early and later pregnancy. And in this, they again say that, yes, it is better to have a diagnosis in early in the case of person with hyperglycemia in pregnancy. This slide is already been shown by Dr. David. The current and new paradigm for GDM screening, this is what we do. If someone is not gestational diabetes, you have to think of type 1 and type 2 or even MODI in a case of if they are diagnosed before it. But the new paradigm is you have to think of early gestational diabetes mellitus. Now, my more important point that's very important, that we are forgetting the people with pregnancy after the, hyperglycemia and pregnancy postpartum. The postpartum glucose assessment is not been done. Many times just because patient is asked or they are saying that now nothing to worry, once it is gone, forget about it. That's not true. Essential for detecting persistent diabetes and impaired glucose tolerance, because that's a window of opportunity for prevention. Baseline assessment for long-term diabetes prevention strategy. HbA1c alone is insufficient. It may be a formal OGTT needed for diagnosis. Now, whether we are doing, I don't do in my practice. I ask the person again to go for regular monitoring, and I'm again a strong proponent of using continuous glucose monitoring. If I feel that they need to be checked or monitored, I put them on a continuous glucose monitoring too. Most women return to normal glucose tolerance. 10 to 30% develop impaired fasting and impaired glucose tolerance too. The regular follow-up of OGTT every 3 years is recommended, and this is what recommendation for postpartum glucose assessment. Why we are worried of this postpartum glucose assessment? Because we are worried of long-term metabolic consequences for mother. She can have type 2 diabetes, that is 50% cumulative risk within 5 to 10 years of post-GDM. And this is very true. We should not forget to teach each and every person who is coming to our clinic for hyperglycemia and pregnancy, they are at the risk of developing type 2 diabetes in their lifetime. So we must explain, we must educate. Postpartum, they must come, and we should do some regular educational program for them. Most of the time, they come back to you after 5 years, 10 years, 2 years, and with frank diabetes. And they come that, Doctor Saab, last time आपके पास आई थी, the pregnancy के time में sugar आया था. This is very common we see. Hypertension, significant increase their cardiovascular risk. Cardiovascular disease increases mortality and morbidity both. Metabolic syndrome, they have clustering of CVD risk factor. Obesity is a challenge. Life course approach, pregnancy marks critical window for prevention, and a cumulative cardiometabolic burden increases repeated pregnancy. Long-term consequences for a fetus. Fetal overgrowth detectable before traditional 24-week diagnosis. Childhood obesity. But I am more worried by most of gynec and OBGY friends. With the pregnancy in hyperglycemia and pregnancy, they decide the date of cesarean section. I could not find anyone, a gynecologist, who is giving them a normal labor even. Not forget about the type 1. We are talking of a person who is first time detected hyperglycemia during pregnancy. No OB-GY persons is giving them a choice of even going for a normal delivery, because they want only 1 or 2 child, and the most of the time they say no, we will go only for cesarean. So that increases more risk, because what we are getting is a low birth weight baby. Most of these baby who are born after cesarean section are between 2.5, and average birth weight of a Indian baby, as per Dr. Yagnik had shown data in 2003, is 2.7 kg only, with a higher fat percentage. So actually that increases more risk for them to have type 2 diabetes, CVD in their adult life. The intergenerational transmission of metabolic disease, definitely those mother and their offspring have more risk of that, and an early intervention during pregnancy may prevent these offspring complications. This is very nice, and Vikranti from my clinic, a resident doctor now, she had passed her, and yesterday night only she sent. Okay, sir, we should propose this. This is like a pregnancy study group, India trials for hyperglycemia and pregnancy. What we should do from normal to emergency. Act fast and screen all. If everyone is not published, so I am giving the name of Vikranti, she had sent me, and I am just putting her slide as it is. The on target, the action is continue medical nutrition therapy, routine antenatal care. The mild high, the action is again optimize diet, activity, consider starting on metformin and insulin if it is more. Moderately high, definitely, and there is a severely sugar is high with a random of more than 200, symptomatic, or they are at the risk of diabetic ketoacidosis, they need urgent, even intensive insulin therapy also. So this is something to explain the patient or educate the patient. We can use these type of slides too. There are emerging therapy and technology. As continuous glucose monitoring, I was disappointed with the WHO statement that it should not be routinely used, but I feel that this is an important device which should be utilized more and more. Insulin pump therapy as and when if you have a type 1 and someone whose sugar is fluctuating too much, I think that should be used. Antioxidant, gut microbiota, AI-driven decision support, even hybrid closed loop system. And now there are some data which are coming for GLP agonist also. They are under investigation for a post-GDM diabetes prevention. So take home message, the South Asians, we Indians, have highest prevalence of GDM and probably early GDM too. Our national data of ICMR, which is InDia study, again sir is, and Dr. Mohan sir was the chief for this, and I was the part of this ICMR InDia study as a principal investigator from Gujarat to show that high prevalence of this early GDM and emphasize the need for screening all pregnant women right from early pregnancy. No significant adverse effect of treating early GDM noted in TurboGM study. The treatment of early GDM is a cost effective, and in many countries have already accepted early GDM screening and others will follow. And more work needed on criteria, diagnostic test and a treatment of early GDM. With this, I thank the congratulating the complete organizing committee of this wonderful meeting of pregnancy study group. A wonderful meeting which they are doing. And thank you everyone, Rutul, Shalini, Piyush, Jimit, Akansha, and all those who are involved in this meeting. Thank you, Chairperson, for giving me this opportunity. And I invite all of you for joining me for my WhatsApp channel, and invite you all of you for World Congress of Diabetes and Obesity from 13th to 15th of Feb at HICC Hyderabad International Convention Center with this organizing committee team. Thank you very much.